think they are added to the Zoom room, right? Just want to make sure that our first speaker is on. This is, I do see him. Okay. Let me introduce Ken Kramer, who is the Vice President of Medical Affairs of Karuna. And I just want to remind everyone, please state your conflicts of interest, and please try to stay to 5 minutes. I always feel rude when I have to interrupt people, but I will have to. So thank you so much. We are looking forward to your comments.
Good morning, everyone. My name is Dr. Kenneth Kramer, and I'm the Vice President of Medical Affairs at Karuna Therapeutics. We thank ICER for their interest in the potential of this novel-acting investigational treatment for schizophrenia in adults, which is currently under review by the FDA. Schizophrenia is an insidious disease that often separates individuals from their lives and families from their loved ones. Schizophrenia is a persistent, relapsing, and disabling mental illness impacting how a person thinks, feels, and behaves, and affects 2.8 million people in the United States. It is characterized by 3 symptom domains: positive symptoms, including hallucinations and delusions; negative symptoms, including social withdrawal; and cognitive impairment. Black Americans are diagnosed with schizophrenia at about twice the rate of white Americans and have worse outcomes. The annual economic burden is estimated to be $343 billion in the United States. We agree with ICER that most of these costs are societal, not medical in nature. And Karuna suggests that future research and economic analysis should comprehensively assess societal costs and benefits, including unemployment, suicidality, incarceration, and hospitalization. Due to limitations with current treatments, people living with schizophrenia often struggle to maintain employment, live independently, and sustain healthy relationships. While current treatments can be effective in managing select symptoms, approximately 30% of people do not respond to therapy, with an additional 50% experiencing only a partial response to treatment. For 7 decades, individuals with schizophrenia have been treated with essentially a single class of medications known as first and second generation antipsychotics. These medications share a common pharmacology, antagonism or blocking of central dopamine and serotonin receptors, predominantly the dopamine D2 receptor. Based on this pharmacology, current treatments primarily target positive symptoms. Unfortunately, current therapies come with significant side effects such as weight gain, metabolic syndrome, agitation, sedation, and movement disorders, including tardive dyskinesia and Parkinsonism. Many patients find the side effects to outweigh the benefits of treatment and decide to stop therapy, leading to poor outcomes. KarXT, xanomeline trospium, is an investigational antipsychotic in development for the treatment of schizophrenia in adults. KarXT is a dual M1, M4 muscarinic acetylcholine receptor agonist with clinical trial data demonstrating improvement in positive, negative, and cognitive symptoms of schizophrenia. Acetylcholine is known to be central to the etiology of schizophrenia. However, medication development has been slow to identify agents that leverage the acetylcholine system in favor of more medications that block dopamine and serotonin receptors. Unlike existing treatments, KarXT does not directly block dopamine or serotonin receptors, representing a new approach to treating schizophrenia. In our ongoing emergent program, KarXT met its primary endpoint in our 5-week pivotal studies, demonstrating statistically significant and clinically meaningful improvements in symptoms of schizophrenia compared to placebo, as measured by the positive and negative syndrome scale total score. KarXT was generally well tolerated, with the most common adverse events being cholinergic in nature and mild to moderate in severity. In clinical trials, KarXT was not associated with many side effects common to currently available antipsychotics, including weight gain, metabolic syndrome, somnolence, and tardive dyskinesia. Our 2 52-week safety studies will be completed and reported later this year, and will have additional safety data, including surveillance for tardive dyskinesia and metabolic syndrome, which ICER has shown in a scenario analysis could have a profound positive impact on KarXT's cost effectiveness. If approved, KarXT would represent the first new pharmacologic approach to treating schizophrenia in more than 70 years. New treatments with novel mechanisms of action are urgently needed for people with schizophrenia because of limited efficacy and poor tolerability of current therapy. The antipsychotic activity and differentiated safety and tolerability profile observed for KarXT in the Emergent program may provide hope to patients and their families. I would like to thank ICER for the opportunity to speak on behalf of the 300+ employees of Karuna Therapeutics who helped to develop KarXT. I would also like to thank those who have given their time to be part of this presentation and to those who took part in this pharmacoeconomic evaluation. Finally, Karuna Therapeutics thanks the patients, caregivers, family members, and clinicians who participated in our clinical trials. Thank you.
Thank you, Dr. Kramer. Does anyone have questions for Dr. Kramer?
Jason, I'd just like to respond briefly on one point to Dr. Kramer, which is that
please.
As you were talking about the safety trials, ICER already made, I think, as favorable an assumption as could possibly be made about metabolic syndrome, in that we assumed that KarXT does not cause it. So it's hard to imagine what could happen in the safety trials that would make that look even better. And on tardive dyskinesia, I would leave it to our experts to say whether they would feel that even knowing what happened at a year, we could be certain that there weren't really tardive dyskinesia effects in the long run. And again, none of this is to suggest that Karuna is doing anything other than what it should. This drug is likely to end up in patients' hands and clinicians' hands long before we know this over the long run. But we also need to recognize that side effects can turn up that we don't know when a drug first hits the market.
Yes, sir. We are also committed to doing longer-term real-world studies once the medication is approved to get exactly at those points.
It's also, I would just chime in, it's worth noting, and this is a problem with any clinical trial, is that aside from things like TD and metabolic syndrome, you never really know if there's 300 and 300 patients randomized. You know, if some unanticipated side effect occurs 1 in 1,000, you'll never know that from clinical trial data. It's a paradigmatic issue in comparative effectiveness research, that before something's used in the regular population, you don't know really anything about rare side effects because of the lack of statistical power in trials. Any other comments or questions? Okay. Oh, Dr. Nichols, please go ahead.
Thanks. Not sure if this is the right place for this, but I'll ask it and you can tell me, hold it for later. Have you considered doing different ratios for your combination to try to get at different adverse effect profiles and tolerability? I guess just something to think about.
There are some ongoing studies that will eventually plan to look at that, and it's an excellent comment. As we know, start low and go slow is always a good policy. But yes, we have had discussions about that as well.
Thank you. Seeing no more questions, let's move. Mark Pomper, please go ahead.
Chiming in a lot here, but I just want to say that the urgency issue is something that kind of gets, you're doing a full and sober and necessary analysis, but the urgency to do something here and to try something new, I just don't think can be understated. And I really appreciate something that looking at a novel approach, a different approach at kind of getting at the medication, and hopefully whatever the costs are initially, if they're successful, they'll come down and become more and more widely used and therefore less expensive. But I think the sense that something has to be done that's different than trying the same techniques that have kind of taken us only so far in terms of treatment. I just can't stress it enough. I can speak to my own experience in terms of stress on families and so forth, and the patients that they've suffered. But really, please take into account that we have to move systematically, understand that, and there are risks to everything. But as is not good enough. It's not even close to good enough. So I just would want to emphasize that.
Thank you for that. I think we're all in agreement.
yeah, we so much appreciate your perspective and the perspective of your family. It's really so centering for us. We appreciate it very much. With that, I will move to Dr. Nagendra, who has prepared comments.
All right, so hi everyone. Again, my name is Dr. Arun Nagendra. I'm a clinical psychologist and the scientific director at the Schizophrenia and Psychosis Action Alliance. We're a nonprofit patient advocacy organization with the mission of dismantling barriers to access and promoting recovery for people with schizophrenia. SNPAA has actively participated in ICER's assessment process since last summer, and we really deeply appreciate the opportunities ICER has provided to share our community's views and needs as they conduct this first evaluation of a schizophrenia medication, which provides our community with great hope due to its novel mechanism of action. We support ICER's stated mission and firmly believe that evidence-based approaches to pricing are critical to fair access in a healthcare system with limited resources. As we all know, antipsychotic medications are the cornerstone of treatment for schizophrenia. We also know that those with schizophrenia encounter a multitude of barriers reaching the specialized treatment they need within our fragmented and under-resourced healthcare system. Pathways to care for people with schizophrenia are complex, involving multiple points of contact before a diagnosis is made and treatment begins. People with schizophrenia often only receive care when they reach a crisis point, which may involve traumatic interactions with law enforcement or involuntary psychiatric hospitalizations. These barriers result in delays in diagnosis and initial treatment, which are some of the strongest known predictors of poor outcomes. Even when individuals with schizophrenia reach care, they encounter challenges associated with prescriber training and stigma, medication inefficacy, safety, and side effects. They often have to try several medications in the hope of finding one that is effective, and many times they don't find one that is effective. The toll of trying one medication after another that doesn't work includes repeated hospitalizations, symptom exacerbation, and immense grief and agony for those affected by schizophrenia and their caregivers. It's estimated that less than half of those with schizophrenia are engaged in treatment at any given time, and that less than 5% of those with the illness receive the full spectrum of best practice services recommended for recovery. It's for these reasons that SNPAA strongly believes that no additional barriers to care should be enacted for those with schizophrenia. We also believe our healthcare system fails those with schizophrenia. Societal costs and associated impact can be impacted greatly by effective medications that have a balance of efficacy and fewer side effects. So we encourage continued research and evolution of associated cost-effective modeling to allow for comparative analysis on how treatments impact these important outcomes for those with lived experience. To this end, I want to speak to the acuity of need for treatment as well as the magnitude of the lifetime impact on people with schizophrenia. As Dr. Tice mentioned, those with schizophrenia have a shortened life expectancy of about 15 years, due partly to side effects from existing antipsychotic medication. Side effects for schizophrenia medications do not just have the potential to reduce life expectancy. They are, as I mentioned, frequently a reason to keep taking medication. They increase self and experience stigma, and they can cause significant mental and physical anguish. Beyond this, the societal cost of schizophrenia extends to lost productivity. Most people with schizophrenia do not work, but most people with schizophrenia report that they want to work. They're just unable to do so. 10% die by suicide, and the risk for suicide is higher in early psychosis, highlighting the need for early intervention and early effective intervention. Those with schizophrenia comprise an estimated 25% of those who are homeless, and they are disproportionately imprisoned, where they are more likely to receive the death penalty and more likely to be placed in solitary confinement. Lack of access to high quality care wrecks the lives of those with the illness and their loved ones. And I'm consistently floored in my role by the persistence and love shown in the face of the agony that many people with this illness encounter, as well as their family members. We hope that the CEPAC will consider the critical need for comprehensive access to all treatment options for schizophrenia without additional barriers beyond the myriad that already exist. We also urge the CEPAC to recognize the profound benefits of new medications and innovation that prioritize efficacy, tolerability, and accessibility. And we believe that the potential impact of KarXT on negative and cognitive symptoms is critical. We believe as an organization that no additional barriers to care should be in place for those with schizophrenia. Thank you.
Thank you. Thank you for joining. Thank you for your expertise, and thank you for your commitment to the care for these individuals and their families, and your compassion for the individuals and their families. Do others have questions or comments, including from the ICER research team, about these comments? Hearing none, let me move on to Lisa. I hope I'm pronouncing your name correctly. Lisa Gordolia, who's a vice president of NAMI South Suburbs of Chicago.
Hello. Yes, my name is Guardiola. That's okay. Thank you. Thank you for having me today. Hello, my name is Lisa Guardiola. I'm very excited to be here and to give my testimony. Just to kind of introduce you and to tell you a little bit about myself, I am 52 years old and am formally diagnosed with schizophrenia. I was formally diagnosed in 2004. I'm 20 years in my mental health recovery journey. And personally, I graduated from St. Xavier University in 2012. I have a bachelor's degree in psychology and a bachelor's degree in studio arts. And it is my lifelong wish to go on to have a master's in art therapy. I work for a mental health provider in the southern suburbs of Chicago as a community outreach and education trainer. And I am also the vice president of NAMI South Suburbs of Chicago. I'm also a sitting board member of NAMI Illinois as well. I have been successful in my mental health recovery in that I have been working for the past 9 years to bring about mental health literacy and to break the stigma that surrounds mental illness through the work that I do. My journey has not been without pitfalls along the way. One of the most important things in my recovery is to take medication every day. With that said, taking medications has not been without its pitfalls. When I was formally diagnosed, I have been in situations where I've had to kind of try a cocktail of medications, or where I had to be weaned off of certain medications for side effects and put on new medications. So it was a process to find something that worked. The very first medication that I was placed on, I've always struggled with my weight, but unfortunately, this particular medication, I packed on 90 pounds within less than 6 months. I was at pre-diabetic, as noted by my primary care physician, which did not help because at packing on the weight and actually being pre-diabetic, I ended up becoming a type 2 diabetic, and taking the weight off has been considerably difficult, trying to maintain a good weight for myself over the years. I also one of the very severe side effects for me was the particular medication that I was on also raised my prolactin levels. So as a woman who was not sexually active, to be lactating was very scary. And also for the fact that I was delusional at the time when this was happening, that was very frightening, because I was having delusions of that I was a direct descendant of Mary Magdalene. So I was having like religious delusions. And I remember when my doctor asked me, was I sexually active? Did I think that I was pregnant? I remember remarking to her, not unless the Immaculate Conception is happening. And so for me, that was very scary to have that side effect going on while I was delusional at the same time. The other symptoms or side effects that I've had are lethargy, fatigue, aside from the weight gain, and the other physical symptom or side effects that I've endured, trying to find the right medication. This makes it very difficult. I do work, and going through an 8-hour day when you have instances of where sometimes you're unable to focus. So, you're getting tired because of the fatigue that is a side effect of the medication, can make it difficult. We as individuals living with schizophrenia have to work, 10, 15 times harder than our individuals that are not diagnosed with a mental health condition. So to have to kind of overcome those barriers of those side effects make it even more difficult to kind of, navigate your recovery process.
Thank you.
Yes.
Thank you so much. Yes, this is such an incredibly helpful and illuminative perspective. I just maybe wrap up the comments in a few seconds. We're over time, if
Okay.
it's possible. Yeah.
No, that's fine. I do want to say thank you very much for having me. I hope I've given you some insight into what individuals that are living with schizophrenia may be experiencing. And I hope that our comments are heard, and that we find a medication that can really help to help the recovery process of those that are living with schizophrenia. So thank you.
It's our pleasure, and thank you. Your comments are super helpful and really help us in terms of our task today. So we're so deeply appreciative for you sharing your story and your time. I'm going to move to Paulie Benjamin, who's the next public commenter.
Yes, hello, thank you. Well, greetings, it's very good to be here. We're pleased and honored to be here, actually. We're Paulie von Edward Benjamin, someone who's lived with psychotic conditions such as schizophrenia most of our adult life. During our life, we've been diagnosed bipolar and then schizophrenic, finally with schizoaffective disorder and with paranoid tendencies. And these are just along some of the just a few of the diagnoses that we've received at various times over the years. Some were much more general, like just obsessive compulsive disorder and things like that. Please note that we also use plural pronouns. I use plural pronouns when we refer to ourselves sometimes too. So schizophrenia and schizoaffective disorder have affected our life in more ways than we can count. Looking back 30 years when we were first diagnosed with bipolar, the main reason for being for that, and that we believe it wasn't schizophrenia, was simply because we were too afraid to speak about like the voices that we heard, the delusions that we had, due to a lot of the public stigma that existed then and still exists, although it has gotten a little bit better. These days, there's more information available from doctors and more support from fellow patients via peer support forums, which has been very helpful. However, a very important thing that's been done more in the medical community now for conditions like schizophrenia and those psychotic conditions related to it is involving the patients more in their own treatment. This is a huge evolution, but it still has a ways to go. Like I said, we've been in the system for about 30 years. We've been in the hospital 4 times. And the last time we were admitted to a psychiatric hospital, it was a rushed procedure still. And this was relatively recently. This was just last year. Even though it had been 20 years since we'd been in the hospital, we have kind of a unique perspective on how things have changed and yet haven't. Not all the people involved were taking their time to find out our personal stance on symptoms. It still felt like the mentality was just get them through the system. We're not saying this is the fault of the people working in the system. I mean, it wasn't our first time in an ER, and we understand that's a very stressful situation. It's simply because this is a system that is evolving from where people with mental and brain conditions are treated like we should just be taken care of by other people, put off in a corner or something like that, if you want to go back old enough. and that our own opinion doesn't necessarily matter as much as the professionals. So now patients' opinions matter much more when speaking to their therapist, but they still are left out of many areas in research and the decision-making process when it comes to the corporate pharmaceutical level. However, organizations like Karuna Therapeutics are taking steps to involve patients, or at least the opinions of patients, from some of the earliest stages of research. Humanity now has technology that enables us to make predictive analysis based on sometimes just somebody's written or oral accounts of symptoms, depending on what you believe about or have experienced with AI. But you see, in this specific way, or in this way, specific behaviors, habits, and coping and managing strategies can all be taken into account when trying to diagnose a patient, figure out the best treatment for them. And this could also be used in R&D. Not just the best treatment available from a professional standpoint, but from the patient's standpoint. Of course, there's still a ways to go in this. We're here speaking for CAR-XT because of this need for involving patients more. This is the mentality that will, in our opinion, lead to much more success in the future. Patients are standing up for themselves now more when it comes to what their doctors are telling them by asking for specific treatments, and that their medical support team takes into account several variables from their personal life that might help in their treatment. Of course, now more than ever, information and support resources are more readily available over the internet. And while not much of that, of course, needs to be taken with the large grain of salt, it doesn't change the fact it is easier for individuals to take the reins and support themselves. So allowing patients the ability to have more input into the overall process of treatment is not just about respect, but we believe can also help with predictive long-term effects and management of treatment. Especially those of us who've suffered for years, and for lack of a better term, we have to kind of make do with what works for us when the system fails. Much of our own personal development towards healthier living comes from our fellow patients and peers. It would be grand if more companies treated our lived experiences with as much respect. For example, although we do currently take medication, overall our experience with pharmaceutical treatments in our lifetime overall has been mostly more negative, primarily because we feel they suppress our own personal emotions too much, and despite how they might help other people. They also affect us in a way that we can't fully express ourselves because we feel too mentally numb. Our current treatment has worked best so far, but again, this is after 20 years of being on and off multiple medications. The number one thing that helps us outside of this is we practice what we practice based on our own personal experience with our conditions. We can only dream of what our treatment would have been like 30 years ago had a system been in place to cater to our own personal reactions to medications instead of just what was kind of generally acceptable for the population. So thank you again. We hope you will take into account that having a patient-focused drive in research and development, not just clinical trials, with more patient involvement from as early on as possible will be more effective because it's actually done with the people who are living with this every day. We're the only ones with a truly subjective and unique, as all humans are, perspective on our conditions. Thank you very much.
Thank you. And I think your comments are just so helpful to our deliberations today, but also so informative for comparative effectiveness research for a whole range of different conditions to sort of involve the patient perspective early on in research. So thank you again for your time. I believe that is the end of the public commenter period. So what I would propose is to give you maybe 4 minutes extra of lunch, and as long as Steve and Sarah agree, and we will reconvene at 12:50 for the voting.